Hello, and welcome back to the Advancing Healthcare Innovation Show. I'm your host, Michael Stamatinos. And if you're new to us, we are super excited to have you here because we bring exciting conversations with exceptional leaders who are painstakingly shaping the future of healthcare. We happen to be very passionate around healthcare innovation, adoption, access, and leadership. And if this is your first time tuning in, let me just sort of share a little bit more about what we're doing here. So we're a healthcare innovation company, and we're focused on bringing stories of innovation within healthcare to life. Our aim is highlighting real people that are truly innovating within our space and giving them the platform to share their stories with the world. And we've got just an amazing, incredibly action-packed year. If you haven't checked out any of the historical interviews and episodes that we've done, make sure you do that now. So hit the subscribe button now to get any of the new interviews that are coming to you. So today, we're thrilled to introduce just an exceptional guest who's been on the front lines of integrated behavioral health. Please welcome Dr. Nelly Burdette, a passionate trailblazer in the realm of behavioral health. She's currently the Director of Populational Behavioral Health at the Boston Medical Center. She carries a mission to advocate for integrated care as a fundamental right for all. And Dr. Burdette's passion, her expertise, and innovation have made transformative impacts across various healthcare systems. She's not just done this once, she's done this many times, and her influence is prominent in the growth and development of integrated care programs. And as the former senior director at the Care Transformation Collaborative of Rhode Island, she championed the integration of behavioral health care from a population health perspective, and her role was pivotal in the provisional of behavioral health care services on the promotion of integrated healthcare within primary care. So known for turning healthcare organizations around, she's paved the way even for Providence Community Health Centers to become the first in the state to receive a gold standard certification for integrated behavioral health. I mean, this is not a small thing. But today, she joins us and she's going to share her insights, her extensive experiences, and her unwavering commitment to a future where integrated behavioral health is universally accessible. So Dr. Burdette, it's amazing to have you with us today. Thank you for being here.
Thank you so much. That was a lovely introduction. Although I might add, I am still at the Care Transformations Collaborative in a consulting role.
Okay, right on. So it's your background is pretty fascinating, and I think we can start in a lot of different areas, but why don't we just sort of start here? When you think about innovation, Dr. Burdette, like what first comes to mind? How do you define it?
Right. So, I like to think about innovation in terms of what things we have a background for that we know could succeed, but maybe there have been barriers or the landscape has not been such that it's been particularly open to it. And those are, risks that we take and one step towards innovation. And then I like to also think about it from a broader perspective around like, what are those things that we all talk about, we wish that were different, we're in passing with our coworkers, and you often hear, oh, if it was only like this, and then really stopping and saying, okay, so what sort of big system level changes would need to happen for those steps to occur, and what could I or individuals or groups of people do to accomplish them? So I really do see innovation on a continuum. They're bite-sized innovations that I like to try to set myself and the people around me to take, because you have to take small steps to get there. And then also, how do we tackle those bigger issues where no one's quite figured it out, and we're all on that process of what could we try that could make a difference in a large way, in particular around the integration of behavioral health in the healthcare setting.
Amazing. So I think when we first had our initial conversation, we totally aligned on the fact that innovation is continuous and that it happens in small bite sizes over long stretches of time. And historically, you have a track record of being able to kind of go in and get stuff done. And especially now, where we're seeing a lot more, I'll say, focus on behavioral health. Can you maybe share with what your area of focus is, and you're sort of newer in this new role? When you kind of go into a new tour of duty, Can you share a little bit about your mindset in terms of going into the new role, and just sort of laying the foundational groundwork? Can you maybe share a little bit more about what your areas of focus are now?
Sure. So I've been in my new role at Boston Medical Center for a little bit over 2 months. And previously, almost had 9 years in. But I do a lot of consulting. And so I'm often in healthcare organizations as a new member to see what is working and what isn't. And the first thing I often look at, and it's what I'm currently in the midst of doing right now, is getting a sense of the culture. I think it's really important when you think about what makes the innovations we've seen work in our lifetimes in history, and when they haven't, is if they've been a fit where the culture is at the organization. And a lot of times it's really important to see if there is a sense of what's now called psychological safety,
Yes.
which has a lot of research and literature behind it that supports it. That's really brought to us by Amy Edmondson, who has her doctorate degree, is at Harvard, has published a lot of great books around this. And before I had this terminology, I would just say, is the culture one that is opening and welcoming to new ideas in the same way that it is to discussing mistakes, to discussing things that you've tried that haven't worked out? Is there an equal space for both of those things? Is there capacity for the group to be creative, but also continue to do the day-to-day things that need to get done? And is there support from the top down, but also from the bottom up? So really just that culture of creativity, but really when I say psychological safety, the feeling that everyone can show up and present any idea, regardless of whether or not it occurs, and feel like they will be heard and not in any way shamed, blamed, or at worst even discriminated against. So this is really important now, in particular with all the work being done in diversity, equity, and inclusion, and a critical component of it. And so this has been my new way of framing, because it just really captures all of it. Does the organization have a baseline of psychological safety? Because if it does, innovation will grow from that. And that's what the research shows. If it doesn't, the good news is you can create it, but you have to recognize which pieces are missing and then have a culture that's willing to say, we want to work on this, we want to grow this.
And I want to dig in more into psychological safety because as much as people want to talk about within healthcare that they're innovative, I think we can all, I guess, align on the fact that we're a little bit slower to move. So would that suggest that maybe there's not as much of a prevalence of psychological safety, throughout sort of our industry? And when you're talking about developing it, can you maybe share some examples of maybe when it wasn't intact to when it was intact, or maybe just dig into some of those areas, please?
Sure. I mean, there is definitely research that supports psychological safety is linked to productivity, right? So when you think about anything, and I don't mean, just like seeing more patients, but productivity in terms of being able to produce, outcomes, results, being able to feel like you're accomplishing and achieving. And so it would absolutely then be completely sensical to say, if we are in an organization that has been feeling stagnant for whatever reason, that a component of that could be, right, that have we assessed whether or not we have a baseline of psychological safety? And so, there are ways of doing that. There's toolkits and there's lots of measures that have been validated. But really, what's interesting about this is it's a measure of how the group feels. So if one person, for example, the boss, says, well, I feel psychologically safe, I can bring my great ideas to the group, everyone listens to me, no one ever tells me I have a bad idea, that is not the definition of psychological safety. That's just one person's experience. So to really understand whether or not your team has it, every single person on the team needs to be asked, ideally in a way that they're able to be kept anonymous, their results shared with only themselves, but that you can see what the group is saying. And then you can really get an understanding then of which components of it are present and which are not, because it's a group dynamic, right? And so if you start to think about different individuals with their races and ethnicities and all the different cultural pieces that form all of us coming together in a group and attempting to be innovative, there will be some people inevitably that will feel more safe to bring their ideas, to, you know, bring out mistakes than others. And so the goal is to create that to where it's felt universally, so that you really have a sense on that team of what the true capacity could be of each individual and then as a team. So, I mean, there's so many examples I could give you of how you know when it's not there. But I think the one that just most recently comes up, because it was in a lot of ways, you know, a worldwide phenomenon, is when COVID was really at its high point. And you could see across healthcare and many other industries that there were some organizations that really seemed to be excelling. You know, they seemed to quickly understand how to pull their resources together, how to get their people on the same page. And even though it was difficult, and you might not always feel good about what was happening in the world, you knew you could count on your team. You knew if you had an issue, you could talk about that, you could discuss it, and you could move on and, you know, find the solution. You could see that there were some teams and some groups and some businesses that essentially, you know, completely collapsed during COVID. And I think there were a myriad of issues, but I think if you didn't have that psychological safety piece, right? So, you know, imagine, you know, there's a pandemic and, you know, you're trying to show up to work and do all the pieces that we're all trying to do. And there's an issue at work and you don't feel like you can tell your boss or your colleagues that there could be a problem. I mean, Amy Edmondson cites in her work that this was a key component in like the Challenger disaster, and she's done case studies around it. Google used her work to identify that their most productive teams were higher in psychological safety than their least productive and least innovative teams. So there's lots of information around this, but I think in healthcare, you can absolutely look to your own teams and see, is there that sense of any idea is a great idea. We want to hear your mistakes. In fact, if you're in a setting where you have medication errors or actual errors to report, that those are all brought forward, right? Because if you can't move past that piece of it, you won't get to the innovation piece. If you're afraid of what might happen to you, or if you might lose your job or lose your respect or power by just stating that there's an issue. And so psychological safety, like it levels the playing field, right? It says everyone brings something important to the table and we need to create a space where we can hear it. We don't have to agree with everyone. We don't have to follow every path, but we can't truly have a space for innovation unless we have that level playing field.
And do you find that having that level of awareness around psychological safety, and do you find that that also translates into patients feeling open and honest and willingness to share things? And can we maybe talk about it from a care delivery aspect?
Sure. So, you know, psychological safety is typically measured between teams, but a team is just, you know, like at minimum, a dyad, 2 or more people. So you could absolutely think about that from a patient care perspective. You know, so how you might see this show up, for example, is if there was a medical care team that was particularly interested and created space for patients to say what was working and what wasn't working. And really, if there was an issue, that they wanted to hear about it, and never when an issue was heard, you know, responding in a way that suggested that there was any kind of criticism for bringing it up, you know. So you would, thank you so much for bringing that up. I'm so glad that you brought this to my attention. And if, you know, I'm the person that made the mistake, I'm really sorry. this was a mistake on my part, on my team's part. I will work to fix it. Or how can I fix it? How could I make it better for you? Right? Like that kind of language would absolutely grow a greater trust and sense of connection between the patient and the medical care team. And, unfortunately, even though everyone strives for that in all the different roles and organizations I've worked in, there's a lot of competing demands that make that difficult to continuously, systematically create. And so I always try to think, what pieces can I control? So sometimes it's tough to think about, well, we only have 15-minute visits in most primary care settings, or, we have so many things in an electronic health record that we need to fill out, or, the payers have a lot of demands on us that we can't all complete, and then also get home to our own families and our own lives. And I really, again, consult a number of organizations that all struggle with similar things. And I try and focus on what can you at least start with within your own team that you can control and improve upon. And then let's start to build out to what your sphere of influence is, and realize what isn't in your sphere, right? So people spend a lot of time, oh, the healthcare system in the United States, the regulations that come down federally have, this issue or that issue. And I think it's good to have, opinions and thoughts about those kinds of things. But if you're not in a position in your sphere of influence to change regulation at the federal level, I generally find it's not as helpful to spend a lot of time stewing and thinking about what could be different if only, this
Right.
piece or that piece.
Totally agree. What you focus on expands. And if your locus of control
Right.
is something that is at a patient level, focus on how you can make that the best possible interaction that you possibly can. And hopefully, that will continue to stack and roll into something there. Let's shift gears a little bit. Let's
Sure.
talk about, population behavioral health. We mentioned this earlier. There's a huge need around behavioral health. Talk about your team. How big is your team? What's the scale and scope of the number of patients that you kind of have that you're sort of overseeing as an entity? Can you share some of those insights if you can?
Yes. So population health is not a new term in and of itself, but
Yeah.
population behavioral health is. So right now at Boston Medical Center, the population health team is a pretty large team. It's close to about 50 people, and it's that large because there is oversight and assistance to 8 accountable care entities in the state of Massachusetts, which comprises of about 500,000 people. And these are people that tend to be the most vulnerable and the most underserved. So these are all individuals that, for the most part, have Mass Health, which is a Medicaid, product in Massachusetts. So that team generally looks at ways of shifting all of these groups, and they range from hospitals to federally qualified health centers to small, mid, and large size primary care practices. So everything from your 1 to 2 doc practice to your larger group practice. And all of these entities have essentially come together and said, like many have in the country, we want to move away from fee for service. We want to move away from looking at how many, procedures we can produce to a value-based way of looking at healthcare. How much value can we deliver? How much of the aims of reducing costs and improving outcomes and really improving, medical team well-being, right, as sort of the aims of value-based healthcare can we provide? So this team does that. There's a lot of data analytics in it. There's a lot of programmatic support to really help practices understand, how do we make this shift? Because for many, it's always been the, previous way of approaching, which is just, we have this many patients, this is who shows up, whatever they ask us to do is what we do, and we just churn, right? And this approach is really different. This is, how can we look at the populations we serve? For example, how can we use data to look at how many patients we have with depression? This is where the population behavioral health component comes in, who also maybe have other chronic medical issues. And are we treating those patients from a racial, ethnic, equity perspective in the way that is evidence-based, highest standards of care? Is everyone getting screened that should be getting screened for depression and anxiety and substance use? Is everyone getting the follow-up that they need? And so it really kind of takes you from that individual patient is in front of me, telling, me as the medical care team what they need, which is still important to do,
right,
but to also that larger perspective of what do I know about the group of patients I serve who are going to the emergency room, maybe unnecessarily, for things that are behavioral health oriented that I could discuss with them and help treat maybe more proactively. So it pulls in a lot of different staff kinds of members. There's nurses who are care managers. There's social workers who also, call or connect with the patient after they've been to a hospital and say, hi, I've heard that you were just in the hospital. I work with your medical care team at, this medical practice, and I'm just wondering if you have all the follow-ups that you need. These kinds of things didn't happen even 10 years ago. This is really new. You would just, as the patient, go to the hospital however many times you needed, and maybe your medical provider would know, but if it was behavioral health, often they wouldn't, because those systems have been siloed. So this is really trying to de-silo, bring that all together, and have primary care in particular be really that front door of having all this information, a lot more resources like psychiatrists, psychologists, social workers, community health workers in the primary care space to help with the components that are not purely medical, right? Because people are less likely to seek these services if you say, why don't you go and see a psychiatrist and, wait and do all that.
Access is paramount. And when you're talking about vulnerable populations, it's hard for me to drum up a very long list of psychiatrists that do take these types of patients. What have you found has been, I guess, most compelling to broaden that group, to get more clinicians that traditionally might not necessarily serve this type of population to want to serve this population? What have you used to do that?
Well, Massachusetts has, I think, a number of innovative approaches that they've taken to try to increase this. And in particular, post-COVID, when we saw quite a dip across the country in terms of new grads coming in or clinicians saying that they're leaving the field. And so a number of things are being offered. Loan repayment, and that differs by the state level, but there's also a lot of federal loan repayment options. In particular, you're eligible when you work with these vulnerable populations connected to either community health centers or federally qualified behavioral health centers. So if you work in either of these types of organizations, that they tend to be the safety nets, and many of them are part of the groups that we work with across Massachusetts. They really encourage people to come from all over the country. They'll help you get your visa if you're outside of the United States and allow you to work and get your hours that you need for your licensure, but they'll also help repay loans. And in behavioral health, there's been even more funding out of this current administration federally to help support paying back loans. So that's from like a recruitment and a retention perspective. But also there are a number of hotlines that have been stood up where primary care providers can call and get a psychiatrist at the state. They can run a situation by them, and the psychiatrist will give them guidance about what to do. So the primary care doctor still has to provide the care, but now they have psychiatrists available. So in Massachusetts, there's MCPAP. These all stand for different things. There's MOMS PRN. There's one for substance use, and all of these are specific, like, psychiatry initiatives as well as counseling initiatives that they can give you this consultation. There's also a new behavioral health helpline in Massachusetts that serves as the conduit. And you can call in if you're a patient or a provider, and you can say, this is the insurance I have, this is the need I have. And they will help talk you through what level of behavioral health care you need, and if your insurance is taken, as well as serve to assist in a crisis and that sort of thing. So the good news is no one has to have it all figured out on their own. There's a lot of systems, and many states have these where you can, call a centralized number and find out more. And then I believe that 988 as the new federal number when you have a crisis of mental health or substance use issues, that you can call in, and that can also serve to kind of help talk through some of the resources in the state if you're in crisis and you're looking to get help.
Super helpful. So from an access standpoint, it's nice to see that there's more options, and that things are coming online and being utilized now to really drive impact, to drive change. Where, let's just say we're fast forwarding a year from now and you're back on the show, what would need to happen within your program in order for you to feel really satisfied about the progress?
Oh, no, that's a great question. There are a number of measures that we are helping all of our ACO partners across the state meet. And they're all connected to best practices. So, how many people are you screening for depression that need to be screened? Are they getting the treatment and follow-up they need? Same thing for alcohol and substance use and lots of other things. And so, you can really see it very concretely because those are reported on a pretty regular basis. And there's incentives tied to it. So, from a very specific framework, you could see if there was improvement in those. And that would mean that sites are offering more and screening more and providing more care for behavioral health issues across this population. So it would be great to see that change happen and feel like, I was a part of the team that helped make that occur. But I would also then go back to the psychological safety piece and say that, I am undertaking initiatives that help understand the level of psychological safety on the team that I'm working with, and many others across BMC who have expressed interest, and then seeing what the baseline is across these different teams. I would then like to be a part of offering different interventions and then measuring again and seeing, did we make a difference? And my assumption is, if we can show that we're increasing psychological safety in teams, that will link to improved outcomes for all the groups that we're trying to help, right? Because if we are a more psychologically safe team, then we'll be better able to innovate and help the other ACO partners meet their goals for patients with depression, anxiety, substance use, any behavioral health issue.
I couldn't agree more. When you talk about psychological safety, it sounds like, when you're standing up a house, you need a really good foundation. And it seems as though psychological safety is a component of the foundation. And,
Yes.
and there's aspects of building a relationship with someone in order to be able to be very authentic and to be in a type of environment where that allows you to be your real self and not feel judged and condemned based on viewpoints. So that to me that's a standard. Like that needs to be a standard, that there needs to be a level of psychological safety in order. I mean, we are in the business of helping people, right? So you want to help the people that are helping the people as much as you possibly can and tend to them. So that is that's something that I think amazingly has been overlooked in many respects. So I'm actually eagerly awaiting and kind of continuing our conversation outside of the show to kind of see how things are progressing. My just sort of the numbers and the metrics, you mentioned about a lot of data and information. What are your sleep well at night metrics? What are you sort of judged on as someone? You mentioned around percentage of increase potentially in initial screenings. What are some of those other key metrics that really matter to you so that when you take a look at something, you can say, hey, we're trending in the right direction based on these metrics? What are those metrics?
So every state has slightly different metrics, but in general, there are many commonalities. And right now for behavioral health, the big ones are if you go to the emergency room for a mental health reason, and this is created because there was a large gap in this,
Right.
are you then getting any kind of follow-up care within 7 days after that? And then there's other metrics that have other time-based initiatives to it. It's even more intensive if there's a substance use issue, because again, as you're probably know, all over the country there's different pockets and a real epidemic related in particular to substance use that's really growing a lot out of the opiate and fentanyl and all of the other kinds of things that are being added to street drugs right now that are available. And so many of those individuals are going into the emergency room to make sure that that life and death moment is addressed. But then after that, there's these really incredible gaps where there isn't any follow-up. And so what happens, unfortunately, is that then you churn and you just go to the emergency room, which does not provide treatment for your mental health or substance use issue. They just prevent, to the best of their ability, a life or death situation. That's what the emergency room is for, right? And so it's really not equipped to manage the way we've created emergency rooms, behavioral health treatment, right? And so really, I would say the most important metrics are making sure that people who go to the emergency room for these, really crisis-like situations, then get the follow-up they need. And there's a lot of different pieces related to that. Some is what happens at the emergency room. Some is then what happens back at the either primary care space or the behavioral health space. And there's a lot to that, because a lot of the times we don't even know when one of our patients has gone to the emergency room. So it's really improving all those systems so we can share that information openly and really all come together to make sure that after that visit, the patient is engaged in some kind of longitudinal care to address the actual issue.
And is that follow-up, because you mentioned sometimes there's phone calls, does it happen in a myriad of ways? Is it also
Yes.
incorporating, in-person visits? I mean, because when you think about folks that have behavioral health issues, and you mentioned other chronic conditions, I mean, sometimes these are the sickest of the sick.
Right.
And I would imagine sometimes they're hard to get a hold of.
Yes.
Have you found early on that there's been an effective way of being able to sort of close some of these care gaps? Is it been telephonically? Is it text message? Is it in-person home visits? Like what have you learned so far?
It's all of the above, right? And it really also depends on the situation that the patient's experiencing. So for example, the most difficult patient group tends to be if there's multiple medical, multiple behavioral health, and then you add homelessness, which, in Massachusetts is, like many states, has pockets where it's just really a difficult area to address. And so home visits means what's called street outreach. So, we are a large enough team in a space where we can have the infrastructure to have street outreach teams that go out to where we know there are places where people congregate, or places where people try to shelter, and meet them where they're at. But there's also virtual visits, telephonic visits, text messaging reminders, and in person. So there's not an expectation that everyone have the ability to manage transportation, childcare if necessary, co-pays if necessary, to come in person to a visit. That's really a more outdated way of thinking. And there's been a lot of innovation around how can we, bring ourselves to the patients instead of expecting the patients to come to us.
Absolutely. And what are your thoughts around inspiration, where are you gathering inspiration from other innovators within our space, or are you taking things externally? And talk a little bit about that, because when you're trying to innovate, let's be honest, like you're not winning a lot of the time.
Correct.
You're doing a lot of learning. Where do you go, to kind of fill your bucket, to fill your cup, just to kind of continue to do that work that you're doing?
Yeah, no, it's such a great point. There's a quote, and I can't remember who said it, but it's something like, when you're not winning, you're learning, right? And it really like flips the idea of, but in particular, it's really true when you're an innovator that you will likely have, so many more failures or things that aren't successful for whatever reason. And it's really how you approach them and how you learn from them that gets you to that one success. And we often look at really innovative and successful people or teams, and we forget that to get to that point, they likely had to successfully get through a lot of missteps, a lot of, false starts, or, maybe even worse, really things that did not work out at all the way they wanted. So the way that I think about keeping myself in a group that focuses on that is, I have an internal peer network. And so those are people that are not in my current work, although some could be, but are people that I've sort of, I guess, collected from either groups I've worked with, other places I've worked, people that I've met just due to common interests, and really making sure that I have what I like to call, and what has been coined, an accountability partner. So
Yes.
these are people who, understand your work, may not be in the same field, and hear your ideas like you are hearing mine today, and then come back to you. You both regularly come back, and you really hold each other accountable. So I think that's really important. So having that close, like, internal network, and that took many, many years to cultivate and grow. And then the next level of that is like a professional network. And those can be people you work with, but those can also be organizations. And so this is where, I really like going to conferences, although you have to be really, I think, thoughtful about the investments you make, because there's just so many options. But one of my criteria for going to a conference, if I'm not speaking at it, is around not necessarily how much I might learn in a presentation, but the networking. Who will I meet that could help me continue to feel like, I'm a part of a group that is, innovative and creative and really pushing to get to that next level. And I'll often even think about, am I missing someone who has a really strong analytical sense, like in my group? Am I missing someone who, has this or that? Because we often look for people who are similar to us. That's like a human nature kind of experience. And so I have to remind myself to actually look for people who are really different from me, not only in their backgrounds and experience, but in their skill sets. And then one more, I think in systems, as you can see, I think of the largest system, which is on a national level. And because my time is limited, is there committees or groups or associations where I might not be that close to anyone, but that I can attend or present public comment around, where I can just hear what others are doing in this incredible space? And I get excited when I hear about innovators outside of healthcare too. So I really have to think, like, who brings me that level of excitement? Right. And so, Amy Edmondson is one of those. I don't know her personally. I've read enough, and I hope to maybe work with her one day, but she's part of that really large external group of, I'm reading these books and, going to places where she's speaking to surround myself with people who are leaning in that direction as well. So I think if you have each one of those three, set up to work at its best capacity, you're in a really great place. But, it does take constant cultivation to make sure that your accountability partners aren't people that are all exactly like you and saying yes to you, and that you're doing great, because even though cheerleading is lovely, it's also really, really important to have people say, have you thought about it this way? Or are you sure you're including everyone? And like really being able to hear that. And in particular, getting people from different fields tends to bring that in.
You basically answered my next question, my last question, or second to last question, which was, imagine someone who's listening in this isn't necessarily involved in an organization or a large organization like BMC, might not necessarily have access to the resources that you have access to. What are the steps that you would tell them? Like, what can you take from this conversation and actually put into action? So, and I don't think you could better articulate it than what you just did in terms of that process. Um, for those that are in our community, how can we best support you in the work that you're doing? I mean, how can we add value to you?
Mm, that's a really great question. One that I don't know that I've ever quite thought about. I think that there's been a lot of work done to destigmatize mental health, behavioral health care, and that work has really been important as we're, going to the doctor's offices as a community, and we're all hopefully being asked about, depression, anxiety, substance use. These are all becoming standard. I think it's really important that we also all be more of our own advocates, and not just around the things we individually experience, but the things that we know could be impacting others. So for example, when I go to my primary care office, and, I sometimes wonder if I'm either the best or the worst kind of primary care patient, but I'll show up, and if I see that there's some like systemic barrier that's happening, I try to find a way to tell my own primary care office, even if it's not related to me. And I think it would be really incredible if there were more people that felt able to speak up, in particular around their healthcare, in particular around behavioral health care, around issues related to stigma. And I think that as that starts to really turn over more and more, we'll start to see that the places that are often overlooked, those that tend to serve more of the underserved, or the rural communities that really are struggling with access right now across the country, or those that have, a really diverse population with multiple languages and ethnicities and are just looking to meet all those needs. I think being able to be receptive to that feedback, and then patients being able to give that feedback, would really create a psychologically safe primary care, integrated behavioral health landscape for all of us.
Amazing. Dr. Burdette, this has been super helpful. It's been wonderful to have you on. And for those that have been tuning in, if you found today's conversation particularly helpful for you, would you mind sharing it? Would you mind commenting? Any type of engagement, interaction where we could learn from it would be most graciously helpful. And yeah, I look forward to having you coming back on the show at some point. I want to hear how things are moving forward, and maybe even some of the measurement around psychological safety from when you started to where, as you kind of going through your next sort of chapter within your BNC story. That's always interesting. So I'm
That would
looking
be
forward to our next chat.
incredible.
Yeah.
You can be one of my accountability partners, and maybe
Hey,
in like
you know what? I think that's what it's going to be. If that's how I'm tasked today, to suit up and show up, then I'll do it. All right. Great.
thank
Thanks,
you.
Dr. Burnett. It's been a pleasure.